Dear friends, welcome back to the Talk with Your Doc show. We have Dr. Walid here. He's a urologist at Thunder Bay Regional Health Science Center. Thank you, Dr. Walid. And you have enlightened us about various risk factors for the prostate cancer and various investigations for the prostate cancer. What is the survival rate of the prostate cancer once one is diagnosed with the prostate cancer?
I'd say it's quite good. I always tell the patient, you know what, you don't have to start worrying about anything for now. It's a slow disease. It's a very slow disease.
Right.
And usually I tell the patients, you most of the time you outlive the cancer. So like 5 years survival is almost 100%.
Right.
And then if you go like for 10 years, like 97, 98%, and same like for 15 years it goes a little bit lower than that.
Okay.
But also it all depends on the grading of the stage of the disease.
Right.
So if you're coming in with like an end stage disease, because of the late diagnosis, probably your 5 year survival will be way less than someone who's just coming in with the initial investigation because of a high PSA.
So prostate cancer has a good survival rate, almost 100% for the 5 years and more even further.
Yeah.
Now, what are the treatment options for the patients with the prostate cancer? I mean, we have read and heard about watchful surveillance, surgery, chemotherapy, radiotherapy, hormonal therapy, and new vaccine available. So can you please tell us about the watchful follow-up or careful follow-up or active surveillance? Can you please tell us who is eligible for it?
So we have two different entities. One is watchful waiting and the other one is active surveillance. Watchful waiting means we just do nothing.
Okay.
And this basically becomes a decision between the patient and the doctor. Let's say the patient doesn't want anything to be done at all.
Right.
And they say, you know what, I will do nothing. If I start having symptoms, I want you to treat the symptoms. So we're not treating the cancer.
So watchful waiting means patient can decide or doctor can recommend that this is an option?
It's a discussion between the patient and the doctor.
Okay.
Active surveillance means someone is having a low risk disease. Like they have prostate cancer, but it's a low risk prostate cancer. It means it's a Gleason score of 6, for example, of 10. And small amount, only less than, only 2 cores from the 6 biopsies or the 8 biopsies. And this, we tell them, okay, we're going to follow up on your PSA, rectal exam, and if we see there is progression, then we can start treatment.
Okay.
So basically you're delaying treatment if till the point that there is progression.
Right.
Until that point you don't do anything, but you're following the patient,
Right.
which is different from the watchful waiting where you do nothing.
Okay. So watchful waiting or active surveillance, what are the advantages of this treatment and what are the disadvantages?
So for watchful waiting, there was a study done, it's called the Scandinavian study, and it has shown that patients who are doing watchful waiting usually don't do as well.
Okay.
Because they basically come back when it's too late to has progressed too much,
Right.
and becomes a hard thing to treat. While active surveillance, it is recommended for patients who are basically are going to be following the rules and coming to the follow-ups. For patients with low-grade cancer and small amount of disease, then we do the active surveillance to see.
So advantages is that you can avoid the side effects of the radical surgery, right?
You're avoiding, we are waiting, and you're waiting to see if maybe your disease does not progress.
Yes.
And you'll avoid having strong surgery, like a big surgery, or radiation therapy, or hormones, or
So those are the advantages of active surveillance.
Exactly.
And disadvantage can be like the disease may progress.
It might progress if you're not following it closely.
Yes.
You might miss the boat.
Right.
And anxiety for the patient. Some patients, they say, I cannot live knowing that I have a cancer.
Right.
While others say, you know what, I'm fine as long as I know that I'm controlling it.
Right. Now, so suppose patient decides that he wants to go for a surgery and not active surveillance or watchful waiting. So what are the surgical options available for them?
So the surgical options would include the main thing is radical prostatectomy, which can be done in different ways. It can be done by open approach.
Right.
It can be done laparoscopically and robotically.
Right.
These are the different ways of doing it. It's one of the most common procedures done in urology, and it has good outcomes, but also it has problems.
Right.
As any surgery in life, surgery doesn't come for free.
Right.
It has complications.
Risk factors. Yes.
Exactly. So patients can have bleeding, infection from the operation. They can lose their erections because the nerves are running on the sides of the prostate, and we do sometimes nerve sparing, but sometimes we can because of the cancer. They can get some incontinence.
Incontinence is one of the most common concern for many patients. So does this incontinence, which is caused, which is nothing but ability to control the flow of the urine, does it come back after some months or some weeks back to the patient?
So for sure it can come back. It all depends on how, like, it has a good correlation with the surgical approach and the surgical experience of the surgeon. It can come back. Usually we tell them to do Kegel exercises, and in few months some patients gain full control. Sometimes they have some small amount of incontinence, but they can actually.
So incontinence can come back, and the lifestyle can be better. Actually,
for sure,
it's not going to be worse.
And if it is a refractory problem, then we can sometimes put sphincters in these patients.
Right. Now, other than the surgery, I have seen many patients being treated with the radiation treatment. And is the radiation first line of treatment if it is a low-grade cancer, or do you treat the patients after the surgery with radiation? How do you do that?
So it all depends on the disease and the extent of the disease and the age and the patient's preference. Some patients don't want surgery; they want to go for radiation. So radiation is like, it can be first line for sure. It's not only surgery. Radiation can be first line, especially for lower grade of cancer, and even in the higher grades of cancer where we think we cannot, with the surgery alone is not going to be controlling. So sometimes we just do the surgery. We do the radiation, thinking that it would give us a good control.
So low-grade cancer, which can be treated just with radiation, or the cancer which has spread and it is very difficult to treat with surgery, we can treat with the radiation.
Exactly.
So the radiations can be external beam, and there is the brachytherapy,
which is basically we implant certain like small implants in the prostate, and this actually emits like the radiation and kills. So sometimes we even do combined approach between the brachytherapy and the external beam from outside.
Oh, wonderful. Now, other than this chemotherapy, other than the radiation therapy, can you please tell us about hormonal therapy and chemotherapy?
So hormonal therapy goes on the theory that we give hormones to block the testosterone, and if we block the testosterone, we can actually get the cancer to be to shrink and to stop like growing.
Right. So there are medications available?
There are medications. We have medications that blocks the testosterone itself, and we have medication that blocks the production of testosterone. So there are many different types of medication that we can use, and the problem, like the side effects of these medication, they can, you get weaker, as if you're going through andropause. You don't have any more testosterone, so the muscle weakness, the person can age, and they have high correlation with cardiac disease as well. So
this hormonal treatment will not cure the patient, but it will reduce the progress of the cancer?
It's basically, I'm putting a hold
on the cancer, right?
As much as I can. Sometimes then the cancer develops ways to bypass this blockage, and they start reproducing again. Then we can go for the chemotherapy, or there is even now newer drugs also taking care of hormones, but on a stronger level. There's a drug called abiraterone. There's another drug called enzalutamide. They're like complete blockade, very strong medications and they're gaining popularity. As well as the non-conventional chemotherapy, which is usually in the castrate resistant, when the patient when the hormones are not doing enough to stop the cancer, then we can give chemotherapy in cases where the cancer has spread.
Okay. Can you please briefly tell about the vaccine for the prostate cancer? We have heard about the vaccine. So what is the vaccine, and how to use it?
So the vaccine, basically, it's Suplusil. It's a vaccine for the patient where we take the cancer cells and we develop a vaccine against it. So we induce the immunity of the patient. So we're not giving you things to kill the cancer. We're giving you actually a killed cancer to induce the immunity to kill, that your own immunity goes and fight the cancer. This is only in cases where it's not first line or second line. This is right now it's for the end stage cases for now. So in the future, probably with further research, this can.
So it's not a vaccine like we have a vaccine for other diseases where you inject the vaccine and you won't get the disease. This is a sort of a vaccine which will help you to boost your immunity to fight against the cancer.
Exactly. The cancer is there, and you're trying to fight it more.
That's good. A lot of information you have given us today about the prostate cancer. Thank you, Dr. Walid.
Thank you.
Thank you so much for coming and participating here. We really appreciate it.
Pleasure.
Thank you for all the viewers for being part of Talk with Your Doc. We will come with you with the next show with the colon cancer and its diseases. Thank you.